Dear folks, today's topic is penicillins. Another session on antibiotics. We have covered most of the antibiotics, but a few are remaining. So we have penicillins today, and then in the coming sessions, cephalosporins, aminoglycosides, and anaerobic antibiotics will be covered. I think that's about it, and polymyxins. So these are the ones we have to cover. Rest we have covered. For those of you who do not know, all these antibiotic video tutorials are up there on our YouTube channel. So for today, we have the Dr. Pruthu DHEKANE. So sir is consultant in infectious disease in Manipal Hospital, Pune and DMH Hospital, Pune. So it'll be wonderful listening to him. He's a ID specialist, and listening to ID specialist is always a pleasure for all of us who are in critical care, because they can teach you the real thing about penicillins, unlike critical care specialists or physicians who may be wanting in certain areas. So it'll be very educative for all of us. Over to you, Dr. DHEKANE.
Right. Thank you very much for those kind words of introduction, and thank you for giving me this opportunity to speak here on this esteemed forum. So I hope my screen is visible and my slides are moving.
Yes.
Right, sure. So I have been asked here to speak about the role of penicillins in ICU. And to be honest, when Dr. Bansal asked me to speak on penicillins in the ICU, my first reaction, as most of others' reaction over here, would be, are you serious? Like, do you want to discuss still penicillin in this age, in this period in which we are dealing with more and more resistant bugs, and we are talking about more and more carbapenems and other newer gram positives in the situation? But then this made me think, and I thought, we should discuss about this. I also went back and tried to look at what all places, still penicillin can be used or is being used. Are we completely over penicillin, or is penicillin still applicable and it can be used in certain situations where it is indispensable? So when I was doing, searching about it again, I was thinking, like, am I trying to follow a lost cause? Because penicillins have, most of us have already done and dusted with the penicillins, apart from a few characteristic areas or characteristic situations in which penicillins are used. Not many of them are in the ICU, maybe 2 or 3. Most of the times, these penicillins have been replaced by other beta-lactams like cephalosporins or carbapenems. So are we digging out a dead grave, or are we actually talking about a molecule which is still relevant in today's practice? So a little bit of history. I know all of us do not want to, or are not very much interested to in the history part, but I'll just go quickly through it, because there are a couple of important things which I want everyone to know, or rather brush up your memories, so that the application of penicillin in today's age becomes more and more prevalent or more important. So penicillin was the world's first antibiotic. It was discovered by the British scientist Alexander Fleming in 1928, and it was an accident. As all of you know, he was working on staphylococcus, and incidentally, he noticed penicillin growing on the culture plate. So penicillin, along with Fleming, Florey and Chain received the Nobel Prize in 1945 for their work on penicillin. And it was a lifesaver. Then it saved a lot of lives from infections, serious life-threatening infections, especially in the war settings as well as in the community settings. The important part about penicillin to remember, or to be highlighted in that, was it was effective even if it was diluted up till 800 times. So the concentration of penicillins, or the minimum inhibitory concentrations that we'll be seeing later on, is something which is derived from this property of penicillin. So penicillin is a group of beta-lactam antibiotics, and as all other beta-lactam antibiotics, these are bactericidal antibiotics. They kill the microorganisms when they're used at therapeutic doses. The main site of action is the cell wall of the bacteria. The penicillins usually inhibit the cell wall synthesis, or the cell wall production, by attaching to the penicillin-binding proteins which are present in the cell wall and blocking the transpeptidase enzyme, which is required for its further synthesis and development. Hence, the bacteria die from cell lysis, and penicillins act only upon the infective or on the pathogenic cell walls, do not kill other cells in the body. So they're pretty much target specific and do not have any other issues on the other cells. A basic classification of penicillins, as all of you already know, penicillins are broadly divided into three groups: natural penicillins, semi-synthetic penicillins, and extended spectrum penicillins. So the natural penicillins are the good old grandfathers of penicillin, penicillin G and procaine penicillin. These are naturally extracted from the parent penicillin molecule. When these were initially used upfront for treatment of most of the things, and are still being used for treatment of quite a few clinical conditions. But then there were some changes, there were some further modifications in this penicillins, and we discovered semi-synthetic penicillins, especially in that we discovered there was the discovery of penicillinase-resistant penicillins. There are quite a few organisms which started developing penicillinase enzymes which inhibited penicillins directly, and hence to counteract these organisms, penicillin-resistant penicillins were developed, which mainly include your methicillin, cloxacillin, dicloxacillin, and other different types of penicillins like flucloxacillin, naficillin, oxacillin, so on and so forth. And these are important because these mechanisms of action, especially penicillinase production, is one of the important properties of causing resistance, especially in Staph aureus, methicillin-sensitive Staph aureus, as we know these days. And hence, one of the drugs used for choice of treatment of methicillin-sensitive Staph aureus critical infections is definitely cloxacillin or flucloxacillin, which we use even in today's age. Then we come to extended spectrum penicillins. As the bugs started getting smarter, as more and more penicillin started to be used in the late 1940s and 50s, slowly we started developing extended spectrum penicillins. These were penicillins which are acting beyond the organisms, which were more of gram-positive in nature and also had actions on gram-negative organisms, especially aminopenicillins, uridopenicillins, and carboxypenicillins. These are the broad three groups in which these penicillins were classified. Aminopenicillins we still use quite significantly these days, especially the molecule amoxicillin is used quite rampantly to the tune of being or sometimes even misused most of the times for treatment of various conditions. Though not very much misused in the ICU settings, because not many patients who require amoxicillin do come over there, but still in the society as whole, we do use amoxicillin quite a lot. And of course, piperacillin is something which we still use in the hospital settings and which has got a good spectrum of activity. So just a few points about these. The natural penicillins are usually acid labile, so they do not come in oral form. Only acid-resistant penicillins like penicillin V comes in oral form and hence can be given as an oral medication. The remaining semi-synthetic penicillins are all parenteral. They do not come in oral form. And these penicillins are nowadays obtained from the parent molecule or the parent source of Penicillium chrysogenum. And the original fungus from which penicillins were derived were from Penicillium notatum. So if we see, we classify the penicillins according to their source, the route of administration, the spectrum of activity, and then we come to the resistant enzymes and the resistant acids. As we discussed, the spectrum of activity is important for us to understand when and how to use these penicillins. Narrow spectrum penicillins are mainly penicillinase producing penicillins, which is again methicillin, oxacillin, naficillin, so on and so forth. Broad spectrum penicillins come mainly as ampicillin and amoxicillin, which we do use. Intermediate spectrum penicillins are still penicillin G and penicillin V, which are used specifically for some classic conditions. And extended spectrum penicillins are piperacillin, which is most commonly used. The other molecules are not so easily available or almost are more of historic interest, as these are more so been superseded by piperacillin. So we are going to discuss more about these antibiotics or these groups inside penicillin, which are useful nowadays. An important part of penicillin, which is one of the unique properties of penicillins, is that penicillin still does come in a repository form. So penicillin G injections are something which can be given once in say 2 to 3 weeks, like benzathine penicillin, which usually is used for the prophylaxis of rheumatic fever. As all of you know, one injection is given intramuscular once in every 3 to 4 weeks. Also, other penicillins like procaine penicillin or fortified procaine penicillin usually have dosage of once every 24 hourly. So these penicillins are basically given in intramuscular form. They create a small deposit inside the local site where these penicillins are injected, and from there is a continuous deposition or the continuous release of the penicillin molecule throughout the system. So it acts as a natural reservoir of penicillin from which a certain dose is continuously released. So one of the unique properties of penicillin, which is not shared by many other drugs, or rather not by any other antibiotic per se, in which there is a reposition at a certain body site from where it is continuously released in a slower form. Also important to know the interaction between penicillin and probenicide. Probenicide is an oral drug which usually blocks the tubular secretion, the renal tubular secretion of penicillin, and hence we get a longer duration of therapeutic plasma concentrations of penicillin whenever probenicide is used along with it. The important reason for stressing about probenicide is because whenever you want to increase the dose of penicillin, or you want to increase the therapeutic levels of penicillin, many times probenicide is used along with it in order when you cannot exceed a certain dose, certain dosage of penicillin by the parenteral route. So probenicide is something which is needed in day-to-day practice whenever a higher dose of penicillin is required. Also, it's important to remember that penicillin is rapid and completely absorbed even if it's given intramuscularly. It is distributed. It has a good cell and tissue penetration, and it has got a rapid renal excretion, mainly via tubular secretion. Right. So now coming to the main part about penicillins, which is the antimicrobial spectrum of penicillins. As all of you know, penicillins are antibiotics which are relatively having a narrow spectrum, or now I would like to say nowadays they are more narrow spectrum in usage because of the development of resistance for penicillins. But still they cover quite a significant range of bacteria in the environment. And to start with, the important bacteria which are covered are gram-positive bacteria, gram-negative bacteria, though a limited spectrum of gram-negatives are covered, actinomycosis, spirochetes, especially treponema, and leptospira. So penicillins are used in the treatment of streptococci, Streptococcus pneumoniae, pneumococcus, Bacillus anthracis, Corynebacterium, diphtheria, Clostridia, and Listeria species. The other uses of penicillins, and I would like to just predominantly focus more upon the ICU uses, is treatment of lobar pneumonias. A patient with lobar pneumonia who is having a penicillin susceptibility can be given penicillins, or can be given an extended spectrum penicillins like piperacillin, tazobactam, with a good effectivity. Meningococcal meningitis, syphilis, especially neurosyphilis, leptospirosis, diphtheria, tetanus, though nowadays tetanus patients are not seen that commonly. Anthrax, there are certain outbreaks of sporadic cases of anthrax in which penicillins are used, and they are a drug of choice. Also, actinomycosis is a condition in which you can have different areas or different involvement of the body sites, which can be either the cervicofacial, the intestinal, where you do get a lumpy growth, and which is not usually amenable to any other group of antibiotics. So it's used in the treatment of actinomycosis as well, and also as a part of prophylaxis for rheumatic fever, bacterial endocarditis, and granulocytosis. So a slightly busy table, but still it's important to go through it. The conditions where penicillins themselves are preferred as first line over the other beta-lactams, mainly in neurosyphilis, congenital syphilis, and pregnancy, where even though nowadays we do give ceftriaxones or other beta-lactams in that place, still the drug of choice for neurosyphilis remains benzyl penicillin or procaine penicillins. I'm not going to discuss too much on the doses because these are all readily available and you can just go through them. If there are some specific points where the doses needs to be altered, we'll discuss on those. So benzyl penicillin or procaine penicillin, drug of choice for neurosyphilis. Congenital syphilis, again, we have to resort back to penicillin G. We have to go back to benzazine penicillin, which is a repository form of penicillin given intramuscularly if there is syphilis in pregnancy, either for latent syphilis, primary syphilis, or even for secondary syphilis. Listeria meningitis is another condition where we use ampicillin more commonly. Actinomycosis, as we already discussed. Borreliosis, Lyme's disease, which we basically Borrelia burgdorferi. Penicillin G is the drug of choice, even if you have other alternatives. Penicillin G given 5 million international units every 6 hourly is having a good response, and there is the sensitivity pattern of penicillin is still excellent for borreliosis. Echinella species, these are usually found especially after bites or animal bites or human bites. These are species which cause mostly skin and soft tissue infections, for which ampicillin is the drug of choice. MSSA, which all of you encounter quite frequently, cefazolin or flucloxacillin, oxacillin is something which is used for MSSA infections, especially MSSA bacteremias, MSSA endocarditis are places where these need to be given on a regular or a routine parenteral basis. Coagulase negative staphylococci like Staph hemolyticus, Staph epidermidis, other staphylococci which are coagulase negative, again flucloxacillin or oxacillin are drug of choice. Though other beta-lactams like ceftriaxones or cefotaxime do act on staphylococcus, the drug of choice is still an extended spectrum penicillinase producing penicillins, which have got better activity and better clearance when used in cons bacteremia. Enterococcus fecalis, ampicillin is quite commonly used. Penicillin G also can be used at a dose of 3 million units every 4 hourly. Leptospirosis, yes, even though we do not use penicillin much nowadays for leptospirosis, but the resistance rates for penicillin for leptospirosis are still very low, and hence in case you're not left with many other options, you can definitely consider using leptospirosis, penicillin for leptospirosis. And then finally coming to the streptococci, for which penicillins are the main drugs which have been traditionally used. For Streptococcus pyogenes, which cause more skin and soft tissue infections, acute rheumatic fever, can also lead to septic arthritis, endocarditis, so on and so forth. Benzyl penicillin 1.2 million units once every day, or penicillin V in the oral formulation can be given 250 milligrams every 8 hourly. And for other groups of streptococci, especially group B streptococci, group C streptococci, which mainly include streptococci like Streptococcus agalactiae, Streptococcus dysgalactiae, these which mainly cause skin and soft tissue as well as bone and joint infections, still penicillins can be used at 4 million units Q6 hourly. The sensitivity again for this group of organisms for penicillins is quite high.
Dr. Pruthu, one thing I want to ask you, this thing for MSSA, is cefazolin the drug of choice, or you can give either of the two, fluclox or cefazolin?
We can give either of the two, flucloxacillin or cefazolin. Okay. Flucloxacillin is still considered to be the drug of choice because it has a lower MIC. Sorry, sir?
Yeah, okay. Just wanted to confirm.
Yes. Because it is because of the MIC values which are there, it has got a lower MIC value as compared to cefazolin for MSSA. But yes, both of them can be given. Cefazolin is a little difficult to obtain practically nowadays in the market as compared to flucloxacillin. But yes, flucloxacillin is definitely first, followed by cefazolin.
That is true. Fluclox is not so easily available. Definitely.
Yes. Right. So as we discussed, going ahead, as we discussed, there are options where we conditions in which we discuss right now, for which again ceftriaxone can be used. But for all these conditions, always there is an option of using penicillins as well. The only thing which is important for these molecules is that nowadays, because of the resistance rate of penicillins, it's not a very good choice to use upfront empirically. For any patient presenting with an acute meningitis syndrome, suspected pyogenic meningitis, or an endocarditis, a pneumonia kind of a syndrome. So it's always a drug which is nowadays more preferable to use once you have the culture and the sensitivity of that organism. We'll discuss that in the upcoming slides. So busy data. So as I was discussing, the resistance rates, the antimicrobial resistance rate as published by the ICMR in 2021. If we see that the top three groups of bacteria which were isolated from a nationwide survey were more of Enterobacteriaceae, non-lactose fermenting gram-negative bacteria, and followed by then Staphylococci and Enterococci. So most of the organisms which we see nowadays in any of the isolate, let it be blood, urine, lower respiratory tract infection, skin and soft tissue, or CSF, still have a majority of gram-negative organisms in there to the tune of almost 70%, followed by Staphylococci, Enterococci, which come about 12% and 6% respectively. So as penicillins are more drug of choices for gram-positive organisms, when your site, even if you have the site or the syndrome in front of you, it's not a very good idea to give them upfront as empirical choices, because the prevalence of gram-negatives, even in areas where there is more common gram-positive involvement, like lower respiratory tract infections or superficial skin and soft tissue infections, is still less. So it's important to understand the changing epidemiology and the changing antibiogram of our surroundings, so as to understand which antibiotics to use and when. Again, a busy slide. I'll just ask you to look at the last column over in here. So in gram negatives in the year 2021, still a maximum number of organisms which were isolated were E. coli, Klebsiella, Acinetobacter, and Pseudomonas, which are almost comprised of about 60% of the organisms which were isolated from a nationwide survey. After that, at number 5 and number 6 do come Staph and Enterococcus, which are predominantly organisms which are influenced, which are treated with penicillins, with an incidence rate of 9% and 2.5%. So again, emphasizing the same fact that it is probably not a very good choice or a wise choice in the current situation to use penicillins upfront. But yes, you can definitely use it once you are having the sensitivity as the identity as well as the susceptibility patterns. Okay, so again, just I would like to like all to just have a look at the bottom table. So these were the total number of gram positives which are isolated from the ICMR study, and even in the ICU, as we see, the total maximum number of gram positive organisms which were isolated were still Staph aureus, which are accounted for about 5.5%, followed by which out of which MRSAs were 1.9%, 3.5% of MSSAs, and coagulase negative of 2.6%. Mind you, these are not percentages, or these are not prevalence of MRSA as a whole. The prevalence of MRSA as a whole in the country is more than around about 35 to 40% at current. This is amongst the ICU patients, where these percentages are especially only in the ICU patients which are there. So if you are suspecting a gram-positive infection, or if you have had a flag on a blood culture, or maybe a CSF which is just showing a gram-positive organism, the chances of this organism being a Staph aureus and an MSSA or MRSA are roughly these percentage. So that's the reason why I wanted to show you this data, so that you can have an idea about the relative empiric therapy which you can use in case once you don't have still the full ID and sensitivity patterns. For Enterococci, again in the ICU setup, 1.8% Fecalis, 3.1% Faecium, and the other Enterococci species about 0.7%. Faecium is a big problem because the susceptibility of Faecium, susceptibility of penicillins for Faecium is pretty low. Faecium in our setup, in the Indian setup, is mostly resistant to penicillins as well as to methicillins, and hence most of the times we end up by using either linezolid or any other vancomycin teicoplanin for treatment of Faecium. But Fecalis is still quite sensitive, up to the tune of at least 56 to 60% of isolates are still sensitive to penicillins, and hence ampicillins, piperacillin can be used for treatment of Enterococcus fecalis. So this is just a graph which shows the trends of Enterococcus faecium and fecalis over the last 5 years. So if you see, it's slowly increasing, both fecalis and faecium, and hence we need to be aware and we need to suspect these organisms even in the ICU setup whenever there is a positive suspicion or a positive flag from the lab. Right. So again, a table, but this is an important table because I'm discussing the MICs of different penicillins against the most different common organisms. And based upon these MICs, we can make a clinical decision as regards whether we can use penicillins or we have to use other beta-lactams like cephalosporins or carbapenems. So if we see the most common organisms over here, I'm discussing gram-positive cocci over here. So gram-positive and gram-negative cocci. So strep pneumonia, strep pyogenes, viridans, group of streptococci, enterococcus, and staph aureus. So the sensitivity or the MICs for penicillin G and ampicillin, amoxicillin are still to the tune of 0.03, 0.05, and 0.12. So still in this day and age, the streptococcus pneumonia MICs for penicillins G is about 0.03. But the break point for this pneumococcal this pneumococcal isolate for penicillin G is just about 0.5. So in that situation, it becomes a little tricky whether you'll be able to attain a good time above MIC ratio for when you're using penicillin G or ampicillin for these kind of isolates. But if you see to the right side column of piperacillin, the MICs for piperacillin are the lowest amongst all the penicillins for the gram-positive cocci. So a piperacillin molecule can be definitely used upfront as an empirical therapy until unless your local epidemiology is grossly different from the national average. If you come down to the enterococci, the enterococci group, the penicillin G, penicillin, and ampicillin, amoxicillin are definitely a no-no with higher MICs of more than 16 and more than 8 in both the sections. Even the MICs for piperacillin and oxacillin are more than 16 for Enterococcus faecium. So definitely most of the Enterococcus faecium species are resistant to most of the penicillins and they require a higher group of antibiotics as you already discussed. Though if you see at Enterococcus faecium, faecalis, I'm sorry, the MICs are still on the lower side and perhaps we can get away with treating these patients with ampicillin or amoxicillin or even piperacillin tazobactams. So if you're having a MIC which is below the breakpoint, at least one dilution below the breakpoint, you can definitely use these molecules with a good effective results for the isolates. Once you come down further to staph aureus and staph coagulase negative staph, the MICs of penicillins are the natural penicillins as well as the penicillin resistant penicillins are still good. And we can use, apart from the methicillin resistant strains, for methicillin sensitive strains, we can still use ampicillin and amoxicillin in a good with a good sensitivity. And for gonococcal as well as meningococcal isolates, still as we see the MICs are less than 0.1. So any situation where the MICs are usually less than 0.1 are usually the situation in which the penicillins are sensitive. So you can use these molecules with confidence if once you have a susceptibility report which is showing an accurate MIC value. So is similar for gram-negative organisms. Popular or more common belief is that penicillins, conventional penicillins are not useful for gram-negative organisms, but it's not like that. We can use penicillins against different gram-negatives like Haemophilus, like Prevotella, like Fusobacterium, so on and so forth. Also, penicillins are effective against anaerobics, against anaerobes. So that is also important to remember. Many times it's thought that penicillins do not have anaerobic coverage. Apart from a certain few anaerobic species like Streptococci or Prevotellas or Fusobacterium, the penicillin molecules do have anaerobic activity as well. And it's not necessary every time to give an additional anaerobic coverage for penicillins in case you are having other organisms. So for Clostridium perfringens, cornemectin, diphtheria, you can still use ampicillin, amoxicillin along with piperacillin. For Listerial meningitis, ampicillin is the drug of choice with a good MIC of around 0.25 and 0.5, and which is used as a drug of choice for treatment of Listerial meningitis. H. flu, Prevotella, Fusobacterium, bacteroids. For these, apart from bacteroids, which has got a higher MIC of 32 and 16, the remaining organisms still have good susceptibilities for ampicillin, amoxicillin, as well as piperacillin tazobactams. So you can use this upfront. Where the main problem lies is gram-negative bacteria, especially the Enterobacteriaceae. As you can see, for E. coli, Klebsiella, Enterobacter, penicillin, ampicillins, amoxicillins have got a very high MICs up to the tune of more than 200 or 150s, so on and so forth. So it's very difficult to get sensitivity for these molecules. If you see, though, the piperacillin MICs, they are still in the lower range. These are below the breakpoints. And hence, once you have a molecule once you have a bug which is having a piperacillin MIC below the breakpoint, you can definitely de-escalate the patient to piperacillin tazobactam. There are some caveats in this. If you're having organisms, especially which are producing AMP-C, there is a chance of overriding this piperacillin susceptibility. But apart from those couple of situations, where your MICs are quite below the breakpoint, you can definitely use molecules like piperacillin for treatment of gram-negative Enterobacteriaceae as well. Though if we go down for non-lactose fermenters, Acinetobacter and Pseudomonas, as all of us know, the MICs are quite high, and hence they are not susceptible for piperacillin tazobactams. Right. So penicillins are also a molecule which are nephro-safe relatively. You don't need to bother about creatinine clearance until it goes below 30 ml per minute for conventional penicillin, as well as for penicillinase producing penicillins. And there is no need of change in renal failure until your creatinine clearance is more than 30. If your creatinine clearance is between 10 to 30, you need some modifications for penicillin G, penicillin V, ampicillin, and amoxicillin, but you do not need any other modifications for the MSSA susceptible penicillins. Though for piperacillin, you have to reduce the dose a little bit, and only below the creatinine clearance of 10, you need to adjust doses for penicillins more further. Though it's important to remember for flucloxacillin, cloxacillin, which are used commonly, we do not need to change doses of penicillins even in patients who are on hemodialysis. What are the adverse effects of penicillins? So penicillins are more known for notorious side effects, though actually in clinical practice, they do not have that much of significant side effects. Earlier penicillins, which were produced maybe in the 1930s and 40s, were less in a purified form. But nowadays, penicillins which come, even though the same molecule is much more in the purified form without a lot of excipients, and hence the primary adverse effects which are from penicillin are very less. Still, you may get the common side effects of having nausea, vomiting, sometimes severe, sometimes skin allergies, rashes, itching. In severe cases, there can be seizures, headache, or watery, bloody diarrhea. But the incidence of these is quite less. We'll discuss it in just a couple of slides. So when we talk about penicillins, the most important thing which comes to the forefront is the fear of penicillins. Or everyone thinks or says that penicillins are drugs which are more likely to produce a severe allergy. Most of the patients themselves come with the claim that they are allergic to penicillins, when they themselves do not know what is the allergy. They themselves are not sure what is the allergy. So it's important to understand whenever there is fear of penicillin allergy, what type of allergy are we talking about over here? So if you're talking about allergy, the IgE-mediated allergy, which are mainly anaphylaxis and early severe urticarial eruptions, these are this is the group in which we need to be just careful about using penicillins. For other type of allergies like serum sickness or delayed hypersensitivity, sometimes the allergy or the frequencies of these allergies are not that common as it is commonly said. Even though whatever studies we have, the frequency or the incidence of IgE-mediated severe anaphylaxis is up to the tune of 0.015 to 0.04% only. Cytotoxic antibody productions and antigen-antibody complex-mediated diseases are even rare when penicillin G is used. though delayed hypersensitivity reactions and idiopathic reactions do happen to the tune of 2 to 5% with further generation penicillins, especially the amino penicillins and penicillinase producing penicillins. So it's important for us to determine if whenever someone says there is a penicillin allergy, what sort of allergy that person is talking about. If there is not an IgE-mediated or severe allergic response, penicillin is not contraindicated for any of these patients. And overall, the risk of this penicillin hypersensitive reactions is also very low. If we see, it's not more than 1% for the conventional mechanisms of action, and even for delayed hypersensitivity reactions, it's to the tune of 2 to 5% only. Other side effects, as we all discussed, are present. More common than allergy, the things which we need to be worried about for using penicillins is more of platelet dysfunction, which is seen with piperacillin tazobactam to the tune of 43 to 73%. Chances of developing neutropenia, especially with penicillin G, oxacillin, cloxacillin, flucloxacillin, and sometimes development of diarrhea, which is commonly seen with oral amoxicillin and ampicillin usage. So these are things which are more commonly used, but commonly seen. But apart from that, other adverse effects like electrolyte disturbances, seizures are pretty much rare, and these are something which need not be considered very high while deciding giving penicillins or not. So after discussing all of these things, have we come to a conclusion that can we still use penicillins? Have they not become resistant, or until and unless we have a good MIC of penicillin, which is lower than the breakpoint, can we use this penicillins? So the answer is not very clear. Yes, what we can say based upon whatever knowledge we have right now, that penicillins still can be used for a various for different types of conditions, but it's essential to understand, or essential to have ID and a susceptibility pattern for these penicillins. It's necessary to know what are the MICs for different organisms for these penicillins, and then only these penicillins can be used. But for certain conditions, which we'll be discussing in the next few slides, penicillins are the drug of choice, and they should be used upfront. As we already discussed, like for neurosyphilis, for listerial meningitis, in pregnancy, these are medicines which are a drug of choice and which have very less incidence of resistance, and they still can be used upfront. So apart from the conventional penicillin, which is penicillin G or procaine penicillin, other penicillins which can be used against different organisms are ampicillin and amoxicillin. Frequency of resistance over here is to the tune of 10 to 20%. Streptococcus viridans are still sensitive to penicillins with a resistance of around 5 to 15%. Not to be used in faecium, but yes, for fecalis, we can use it. For penicillinase producing staph, the resistance is quite high, which is methicillin resistant Staph aureus. It is quite high to the tune of 50 to 60%, as we already discussed. So it's a no if you're having a penicillin resistant or a methicillin resistant staph. But for methicillin sensitive staph, you can definitely use flucloxacillin or cloxacillin. Also for gram-negative cocci, as we already discussed, the resistance rate, especially for meningitis and gonococcal infections, are not that high. And hence, we can use ampicillin, amoxicillin in these situations without much of an issue. Again, the same table in which resistance patterns have been mentioned. What I want to show from these tables is especially what options do you have in penicillins. As we can see in the first one, penicillin G is something which is applicable or which is susceptible to most of the organisms. And apart from a couple of situations, like for Bacteroides fragilis or like for MRSAs, where penicillin G cannot be used, if you are having the susceptibility for penicillin G or procaine penicillin, you can definitely use these penicillins. If penicillin G is not an option with you, you can definitely use the amino penicillins or the penicillinase resistant penicillins like ampicillin, piperacillin, which are as effective as any other further beta-lactams once you have the drug sensitivity with you. Right. So coming to the next part is, not using penicillins alone, but using it with the combination of a beta-lactamase inhibitors. So beta-lactamase inhibitors, as all of you know, is one of the mechanism of resistance, which is developed by different organisms, both gram-positive as well as gram-negative, and hence to counteract that, we give a beta-lactamase inhibitors, which help the parent molecules, which are like amoxicillin, ampicillins, piperacillins, to act on the drug or act on the organism or the substrate. So it's important to know that in BL-BLI combination, still the active moiety is the beta-lactam, which is the ampicillins and amoxicillins. Meanwhile, the clavulinate, sulbactams, tazobactams, so on and so forth, are mainly for protection of these parent beta-lactam molecules. So whenever we are using these molecules, especially the molecule which is most commonly used nowadays is piperacillin tazobactam, and the sensitivity for the minimum inhibitory concentration for piperacillin tazobactam for various organisms is still quite good. So if we see for for MSSA, piperacillin tazobactam is having an MIC of 1. For H. flu moraxella, it's still 0.06, 0.15. For E. coli Klebsiella, it is still slightly higher, 2 and 4. Proteus, good, relatively 0.5. Bacteroids, 2 on the borderline. For Enterobacter, Serratia, Citrobacter, 1 to 8, definitely not good. And for Pseudomonas, also nowadays, we are having a lot of species which are resistant to piperacillin tazobactam. So what I want to show is that piperacillin tazobactam amongst all the penicillins still is having good susceptibility and good MICs for different organisms at different sites, and it still can be used once you have the drug susceptibility report. So it's important for us to make sure that proper samples are sent in time for cultures, and those samples need to be processed also properly by the labs in order to give a correct MIC, and hence we can use in these situations BL-BLI combinations and need not go to the carbapenems and the other higher antibiotics. Again, talking a little bit more about the beta-lactam inhibitors. So as all of you know, not only with penicillins, there are other cephalosporins with which beta-lactamase inhibitors are combined, especially tazobactam, avibactam, vaborbactam. They're also combined with carbapenems like meropenem, vaborbactam, imipenem, relibactam. Ceftazidime avibactam is something which all of us use quite commonly. So it's important for us to know which beta-lactam, which is the beta-lactamase which is being produced by the organisms. And as all of you know, and all of you must be practicing in your setups, that we do certain molecular tests to find out which beta-lactamase is being produced. In case of penicillins and cephalosporins, it's important to understand which class of beta-lactam is there, because if you see over in here, the class D beta-lactams, which are mainly the OXA48, the OXA23, these are the classes which can be inhibited with avibactam. So combination of ceftazidime with avibactam will inhibit any organism which is producing these beta-lactamases. So it's essential to know the beta-lactamase production, and I urge all of people who are not still using the beta-lactamase production genotypic methods like the expert carbar to use them upfront, so as to get a better idea about the understanding mechanism of susceptibility for the organisms. So going ahead, an important part for understanding penicillins, especially from the ICU standpoint, is also penicillin allergies. And if you are having penicillin allergies, what to do? So most of the times, as we already discussed, penicillin allergies are something which are more of an irrational threat rather than actually being a penicillin severe hypersensitivity reaction. But in case there is a known or there is a suspected high suspicion of a penicillin allergy, we need to do penicillin desensitization, and we need to navigate through a penicillin allergy. So what do we do when we are confronted with a patient who is having a suspected penicillin allergy? The most important part to do is, first of all, to take a proper history to understand whether what type of allergy the patient had, when the patient had the last allergy, when did the patient have the symptoms last time. So if it's an episode which has happened more than 10 years ago and which is only limited to pruritus without any rash, there is a very low risk of of having a similar kind of an effect if you give a re-challenge with penicillin right now. If the episode has happened in the last 10 years, and if there is significant rash or clinical symptoms which are suggestive of angioedema or urticaria, then we need to be a little careful and follow the protocol which we can see right now. The protocol for desensitization of penicillin, it is usually done either in the intravenous or by giving an oral challenge. So usually a 250 milligram or 500 milligram challenge is given, and the patient is observed in case there is a low risk of penicillin allergy in the past. In case there is a high risk of penicillin allergy, like an Ig-mediated reaction, like with hives and anaphylaxis, intradermal penicillin testing is the next step, which is recommended. If the intradermal skin testing is negative, we go back to the oral challenge with oral amoxicillin. If the intradermal penicillin skin testing is positive and a patient still requires penicillin, we require a systematic penicillin desensitization. If an intradermal penicillin skin testing is not available, we can give a graded challenge with a cephalosporin. And if the patient tolerates full dose, small doses, he can slowly be shifted up to higher doses. So penicillin desensitization is required for persons who are having actual documented penicillin allergy and for whom no other therapeutic options exist. Always do penicillin desensitization in the ICU settings. Oral desensitization is preferred anytime over the IV desensitization. Make sure that you're stopping all the beta blockers before you start the desensitization process. Always have an IV access, epinephrine, and mechanical ventilation at standby in case the patient has any severe reaction. And usually 1/3 of the patients develop mild transient reactions during the desensitization course. So for mild transient reaction, there is no need to stop the re-challenge process. You can always slow down the re-challenge process and continue until all the steps of this penicillin challenge are completed. So on the left-hand side of the screen, you can see that at 15 minutes interval, there are approximately 15 to 20 steps or 15 to 20 in intervals of 15 to 20 minutes each. Slowly, a graded dose of penicillin is given in concentrations for the first 4 being about 100, and then 1 log concentration being increased every hour. We continue that for around about 4 to 6 hours, in which a graded dose of penicillin is given. Finally, a cumulative dose of penicillin of about 50 lakh international units is reached, which is 5 million units. And if the patient can tolerate this much, then the patient can be given a proper dose of penicillin as a therapeutic dose going ahead. For oral desensitization, usually the same steps are followed every 15 minutes, only that oral penicillin V, is given diluted in water, and the cumulative dose is calculated up till about 1.2 million units. And if the patient tolerates that, then a full dose of penicillin can be given. So